training. My co-founder is Dr. Rajesh Dash. He's a cardiologist at Stanford. The inspiration from HealthPals came from his observations of the gaps in clinical care in his practice. We're lucky to have some great advisors who know what it takes to effect change in healthcare. According to the CDC, 80% of heart attacks and strokes are preventable. Yet, according to a RAND study 10 years ago, only about 50% of clinical decisions are guideline-based, and that's suboptimal. Now, there are other studies that show that if you improve adherence to guidelines, you can actually decrease mortality and events, driving better outcomes. Now, if you account for individual variability for each patient, you can really minimize preventive errors. The solution is mapping patient data into evidence-based treatments. We call this precision prevention. Our product is Clint, or clinical intelligence. It combines machine learning and medical science to be able to identify and close care gaps at the population and point of care. You can take an example of George. George is, a clinician can look at George's risk and what are the contributors of that, of risk factors to the overall risk. And if you add guidelines, you can actually provide something at the point of care. Now we can aggregate this at the population level to be able to prescriptively look at guidelines and best practices and use the predictive algorithms to see what is the impact of closing those care gaps. This is the bottoms-up approach to population management. It's combining two usually disparate realms of clinical decision support and population management to be able to drive clinically actionable insights. I'm a data scientist, but machine learning itself is not clinically actionable. But machine learning can optimize treatments within the guardrails of evidence. Over the next 9 months, we'll be running Clint on 250 million patient life years of data. We work with hospitals, pharma companies, and tech, including a big 5 tech company. And we have a data and business partnership with the American College of Cardiology. This is what we're looking to deploy in the next 24 months. For example, in India, we're actually looking to deploy at a population level to find care gaps, then use machine learning to come up with the right protocols for that health system, and then actually deploy and measure the impact at the point of care. Thank you very much for listening, and I'd be happy to talk to people who are interested in using Clint, as well as funding the rapid growth of HealthPals. Thank you very much.
Great. So my first question is, you know that you got Bob Harrington involved. Is that a questionable executive decision?
Yeah, it's still on the, we're still on the fence. Yeah.
Question? Lee?
So in terms of how you see this being deployed, is it through the provider's doing the risk assessment, or are you looking at going through plans or governmental agencies, NGOs, and applying population level data? It wasn't clear to me where you were using Clint.
Great question. So in the go-to-market, really it starts with data and the data insights that we have, longitudinal data. And right now we're focusing on 3 segments: tech companies who want to go into healthcare, who can use this as insights as a service and not the whole care gaps, and pharma companies who can look at medication care gaps for optimizing clinical trials as well as for the sales and marketing, and then actually single-payer systems internationally. For example, we've already sent proposals to the couple of states in Australia for statewide deployment.
Bill?
So you talk about the data. You're using longitudinal patient data, presumably EHR and administrative data. Where are you getting your psychosocial inputs from, your social determinants of health, and all of the others that would make this better than the existing?
Yeah, great question. So right now we're focused on EMR, lab data, and registries. And with tech companies, we're actually working on extending this to clinical trials. Our next step in our roadmap is to be able to look at social determinants of health and other psychosocial.
Where will you get it? Where will you obtain that data?
Yeah, so we're looking at actually insurance companies who have some of that data, and other partners, healthcare partners, digital health companies who would have some of that data.
Go ahead, Anne-Marie. Mic is off.
How about this? Why do you need AI to tell a patient if their blood pressure is high or they're not on a statin? It seems like a lot of the gaps in care that you're quoting are basically gaps in achievement of guidelines. Where does AI actually come into this? It sounds nice, but what are you actually doing with it?
Yeah, great question, Mary. So at the point of care, we're not actually using machine learning except for existing risk assessment algorithms. That would also need FDA clearance. At the population level, it's to actually help design protocols that fit for the individual health system. So to be able to look at all the treatments, let's say you have 10 recommendations, statin, lifestyle, others, what actually ended up moving the needle if you look at data for that particular patients like them, and with similar medical histories.
So how do you get this worked into the workflow? Are you integrated with Epic?
Yeah, so commercially, our product is actually only at the population level. So we don't actually need integration. We actually look at get de-identified data from a health system or with our ACC data partnership, and it's a much easier starting point. And a phase 2 would usually be at the point of care, where we would use Redox to actually implement with different EMR systems.
Pull it out, but you can't put it back in with Redox.
You actually can with some systems.
Under certain circumstances, I suppose. Bill?
So, just very quickly, you mentioned 2 use cases: a population use case for more public health or administrative, and a point of care. How do you reconcile those two as the same tool?
It is exactly the same insights, but so for example, for George, we would just be having, let's say, 500,000 or 1 million people like George in a cohort, and we're actually showing the care gaps at an aggregate level. So basically, it's a statistical aggregation of all of these patients. And so every single recommendation that we provide is clinically actionable. So if you were at the point of care, a clinician with a patient, you can actually use those recommendations.
You mean as a guideline, but not as a specific patient predictor?
Sorry?
Not as a specific patient. It's not George seeing George's data. It's George seeing a population's data?
Yeah, so you can drill down to George. You can go all the way down and click into George. But you're looking at this to say, okay, I want a patient cohort of the pre-hypertensive patients. So I can look at any cohort.
Eric?
Yeah, so I'm not so sure the problem is identifying the gap as much as it is the problem of actually trying to solve the gap. So reporting back to health systems that there's a lot of patients who are not treated with blood pressure will not necessarily get more patients treated with blood pressure.
Agreed. Do you give specific recommendations on how to correct those gaps?
Yeah, that's a great point. And we're actually starting with, and that's part of the reason that in our go-to-market, we're starting with pharma companies and tech companies who just want to understand identification. And we're working with, the next step is to work with health systems to have both identification and execution, which is harder, as all of you have pointed out.
Okay. Really quick question. We got 3 seconds.
Yeah, I want to follow up on Eric's point. I think the work he's done has showed that even despite giving them alerts, people don't actually take action. So do you have any data that this population health platform actually
Doctors don't listen, is that your point?
They don't
Didn't
listen.
know that.
So we have a clinical trial that we've done at Stanford that combines the execution with the plan itself to actually, let me see if I can pull it up here real quick.
Provides a small electric shock to the doctor when they don't respond.
That was a nice to have. And so we actually showed a 33% reduction in refractory patients over 3 months. But yes, this is the execution and the implementation as well.
Okay.
And this is for a small population. We're looking to try this out for large.
Great. Thanks so much.
Thank you so much.
All right. So judges, be judging, please. Audience, okay.